Uh, okay. So today we have Dr. Shamla and Dr. Al-Khatib and Dr. What's the third name? So Dr. Shamla, are you there?
Yes, sir.
Okay, yes. Okay, so Dr. Shamla, you will take the case today and we will be running through different topics today. So please, doctor, be with me because it won't be only the case that we will discuss. We will discuss many things related to the case itself. So I want you to learn what we will discuss beside the case itself. It will be the approach for the case. So just to remember, I want to start by telling all of you, as I'm usually saying, the PACES is a game. You need to learn how to play the game. Okay, so it's not about your knowledge. You already have a great knowledge by passing first and second part and by practicing. But what we are looking for is to learn the approach that you can follow when you have a very short time or pressure of the time during the PACES exam. That's why I want you just to close your eye and memorize our algorithm or memorize our mnemonic page so you won't waste time thinking or remembering that in the exam. It's not about the knowledge. Everyone know how to treat, rheumatoid arthritis, how to catch this and that case, but the point is, I want your mind to be organized enough to recall the knowledge during being in the exam, okay? I will start sharing my screen now. So let me, okay. Let me share the presentation or I'll share. Yes, okay. So Dr. Shamla, do you see my screen now?
Yes, doctor.
Okay. Okay, so for everyone, let me before doing that, I will just close the chat. So because I will be asking question and I don't want you to be distracting the candidate. So let me participant can chat with host and now you can only chat with me. Okay, so when we ask a question, I want to see your answer only, not everyone, so you can test your knowledge as well, okay? So Dr. Shamla, this is Mr. John Akopian, and this is a history taking station. And for the doctors who didn't attend with us before, we have two approaches for the history. We have the bundles way and we have the regular with system review way. I will go through that after finishing the case. And I will go also through many different other topics than what we have in the case related to the same complaint. So stay with us. The second issue is Dr. Shamla will show us today a full practicing on a history station. Dr. Shamla, I don't want you just to focus on knowing the diagnosis. I want also to see a perfect performance for the history station. I'm reminding you, don't forget the structure of the case. I mean, don't go out of the history station without asking the family, the social, the impact on the patient life. All this stuff is needed. So I want to give you a full evaluation for your performance today through practicing this case. So this is Mr. John Akopian, and he is 72-year-old, and you are the doctor in the internal medicine clinic. And this is a letter coming from the GP saying, thank you for seeing Mr. Akopian. He's 72-year-old man who has been complaining of recurrent abdominal pain and weight loss for the last 3 months. His past medical history is significant for long-standing diabetes, hypertension, and coronary artery disease with 2 coronary stents. You're faithfully. So this is the case. You all have 2 minutes to prepare yourself. Usually in the exam, you will have 5 minutes. But now just put your differential diagnosis. If you have an approach, please write it on the side. And let's start practicing this case. Then we will discuss exactly how to approach the most of the common cases of the abdominal pain in the PACES exam. Okay. Two minutes, Dr. Shamla.
Okay, sir.
I want you to relax, okay? Okay, doctor, I think we can start now. Dr. Shamla, are you
Okay,
there?
sir. Yes, sir.
Let me start your timer.
Okay.
And please, for other doctors, this should be interactive lecture. So I will be asking questions during the lecture, and I will be expecting your answer to come to me in the chat box, okay? So let me give you the time. Okay, Dr. Shamla, you can start now.
Hello, I'm Dr. Shamla here, one of the doctors in clinic today. You're Mr. John, 72 years old. Am I right?
Yes, doctor. Yes.
Yeah. Mr. John, may I know what brings you here today?
Yes, doctor. I have an abdominal pain that is happening frequently. And this is, I tried many over-the-counter medication and still have this pain. And it's, I'm very worried about this pain, doctor.
I'm
And
so sorry about
this
that.
pain since 3 months. I didn't have this pain before the 3 months.
Okay. So this pain, like when it started and now, is there any difference? Like, is it increasing or is it the same?
No, it's severe, doctor. Sometimes, yes, I felt it's more severe now, but since start, it was not an easy one.
Okay. Where exactly is this pain located?
It's in my tummy, doctor, but mainly in the upper part, but sometimes it affects all my tummy.
Okay. Is it like any part of the day it is like more?
Any part of the day?
Yeah, like if it's increasing in the daytime, like after the food, before food, any
Yes,
relation?
doctor. It's always after the food, doctor. It starts around, I would say 30 minutes of eating anything.
All right.
Yeah.
Okay. Do you have any vomiting associated with it?
Vomiting? No, doctor.
Okay. So is it coming daily, every day,
Yeah, doctor.
after
When
all the meals?
If I will eat anything, I will get the pain within 20 to 30 minutes, and this is why I avoid eating.
All right, all right. I'm so sorry. Let's see what we can do about it. Mr. John, may I ask if this pain is like going anywhere other than your tummy? Like, is it
No,
radiating to any other place?
it's mainly my tummy, doctor. It's mainly my
Okay,
tummy. Mhm.
okay. So anything is you said the food is making it worse. Anything making it better?
Stop eating, doctor. When I don't eat, I don't have the pain, and usually after 2 hours of stop eating or after my meal, I feel improvement. That's why I'm
Okay.
trying to avoid eating as much as I can. And I think this is the reason why I lost a lot of weight.
All right, all right. Have you noticed any change in your bowel works recently?
Not really, doctor.
Okay. It's normal only, like how you used to pass the bowel motion, it's the same.
Yes.
Okay. Have you noticed any blood in the stool? Any color difference of your motion?
No, doctor. No.
Okay. Okay. You said you don't have any vomiting.
No, doctor.
Okay. So would you be able to tell me how much weight loss you had in this time?
Yes, doctor. I lost around 15 kilograms or 14 kilograms in the last 3 months.
15 kilograms.
Mhm.
Okay. I'm so sorry about that. Do you feel any fever, increased body temperature?
No, doctor.
Okay. Any lumps or bumps in the body?
No.
Okay. Any sweating, increased sweating?
No, doctor.
Okay. Mr. John, can I ask you a few questions which may be related to your condition?
Yes, sure.
Okay. Do you have any temperature preferences recently?
No, doctor.
Okay. Have you noticed any discoloration of your skin?
No, doctor.
Okay. How's your water work? Any frothing,
Yeah,
any color difference?
it's frothy, doctor, and they told me the doctor told me that my diabetes start affecting my kidneys badly.
Okay. How about your vision? Do you get any blurry vision? Any vision problem do you have?
Vision?
Yeah, in
Yes,
your
doctor.
vision.
I also had a lot of troubles with my eyes, and I had a laser surgery done in both eyes 1 year ago.
Okay. May I ask what do you take for your diabetes?
I'm taking medication pills, and but my doctor advised me to start insulin. But to be honest, I refused that because I'm very worried about the injections. But
Okay.
he told me that my A1C is above 10, and he told me that it's very important to start insulin. I'm still thinking about it.
Okay. Okay. I'm so sorry about that. So how often do you consult your doctor, GP?
I see him regularly because of the diabetes, and I see all the other consultations they ask me to do as a diabetic.
Okay. Do you get any tingling, any pins and needles in your hands or legs, foot?
In my legs, doctor, in both my legs, yes, a lot of pins and needles.
All right.
And you know
All
what,
right.
doctor? I got two ulcers in my leg, and I'm following with the foot care doctor.
Okay. Do you get any time like low sugar, like you go your hands are trembling, you feel sweaty, you feel uneasy, you're
Yeah,
hungry?
I got that only one time 6 months ago, and I remember that I took the medication and I didn't eat my breakfast. So I think this was the reason. But since that time, I'm taking my candy in my pocket and I use it whenever I feel dizzy or sweaty or something.
Okay. Do you feel any difficulty in swallowing?
Difficulty in swallowing? Not really, doctor. No.
Okay. Any rashes or any sores anywhere in the body?
No, doctor.
Okay. Other than your diabetes, high blood pressure, and heart disease, do you have any other medical conditions?
Yes, I have high lipid level, and as you said, I have problem in my heart, and I have this stents done for my heart years ago.
Mm-hmm.
And I had a problem in my gallbladder before, but it was removed 10 years ago.
Okay. Okay. So for high blood pressure, what medication are you taking?
I'm taking aspirin, clopidogrel, atorvastatin, metformin, sitagliptin. I'm taking also enapral, and I'm taking amlodipine.
Okay. Every day you're taking without fail.
Yeah, I'm taking my medication regularly.
Okay. Do you have any other than this tummy ache? Do you have any other pain elsewhere?
Yes, doctor, I got pain in my legs when I walk more than 50 meters.
Okay. And when you stop walking, does it improve?
Yes.
Okay. Mr. John, may I ask, are you taking any other over-the-counter medication other than this high blood pressure, high blood sugar, and heart disease
Mm,
medications?
no, doctor.
Okay. Have you taken any medication for this tummy pain?
Yes, I tried the paracetamol, and I tried to take ibuprofen, and my GB advised me not to take it because of my kidney problems and my stomach problem as well.
Okay. So this ibuprofen tablet, how many you used to take and for how long you used to take?
No, I just used it twice 2 months ago, and I didn't use it again.
All right. So have you been hospitalized any time before?
No, doctor. Only
Okay.
only at the time of the stenting when I got the chest pain and I had this heart attack. But since that
Okay.
time, no.
Yeah. Have you checked with your heart doctor recently? Is the stent working properly?
Yeah, I saw him last time 8 months ago.
Okay. What did the doctor say?
Yeah, nothing. He told me just take your medication and give me some advices about my life and control my stress and all this stuff.
Okay. Do you have any racing and pacing of heart these days?
No, doctor.
Any shortness of breath? Any difficulty in taking breath?
Not really, doctor. Just when I have the pain, when I have this pain, I feel like I can't take a deep breath because of the pain.
Okay. Do you have any cough?
Cough, no, doctor.
Okay. Any yellow discoloration of your eye?
No, doctor.
Okay. Your waterworks, you said it is frothy, right?
It's frothy. Yeah.
Okay. So, Mr. John, may I ask, what do you do?
What's my job? You mean? I was a barman. I was working in a
Okay.
bar for years, but in the last year, I have a lot of sick leaves, and with this pain, I can't continue.
Okay. I'm sorry about that. Do you need any support? Any
No, I'm good, doctor. I'm good. My
okay.
my daughter helping me.
Okay. So you're staying with your daughter, is it?
Yes,
Okay. Are you comfortable at home?
yes,
Okay. Can I ask few personal questions?
yes,
Yeah. Do you smoke?
yes, doctor. I smoke. I used to smoke up 20 to 30 cigarettes a day in the last 40 years.
Okay. So you're smoking 20 to 30 cigarettes now also?
Now it's less. I'm just smoking 5 a day.
Yeah, Mr. John, let me tell you, any amount of smoking is bad for health, okay? Especially considering your condition like high blood pressure, heart disease, and high blood sugar. I would request you to stop it completely. If you need any help, I can get you in touch with the smoking cessation clinic. Is that okay?
Yes, this would be great, doctor. I tried many times and I failed. So it will be very nice for you to send me somewhere to find someone to help me with that.
All right. How about your alcohol intake?
Yeah, I'm drinking about 3 cups of whiskey every day.
Okay, so alcohol also, as I said about the smoking, is very dangerous for health. If you could cut down or stop it, it would be
Two
very good.
minutes remaining, doctor.
Okay, so do you have any significant family history?
Significant family history?
Any
I don't know,
medical
doctor.
conditions?
I don't know. I
No.
never lived with them.
Okay. May I ask if like you're sexually active?
No, doctor.
Okay. Uh, Mr. John, do you have any concerns for me?
Yes, doctor. I'm very worried about losing weight. I read about abdominal pain and weight loss, and I found that it might be cancer, especially in my age. So I'm very worried about cancer, doctor. So please tell me, is it cancer?
I really appreciate your concern, Mr. John. It could be cancer also because the weight loss is very significant, but there are no nasty signs of cancer in you, like blood in the stool or vomiting blood or any other things. So, what I think is I can't rule out cancer in this stage. I need to, run some tests. I need to take
So what do
more
you think my
history from
problem,
you.
doctor? If it is not
So,
cancer, what could it be?
what from what you said, I think there could be a soreness, like ulcer in your tummy.
Okay. But
Yeah.
I was prescribed a medicine for that. My doctor
But,
gave me some medications also for the sores in the stomach, but it didn't really help.
what medication was that?
I can't remember the name, maybe omeprazole or something.
All right. So have you regularly taken that?
I took it for 2 weeks and it didn't help.
So you stopped by yourself?
Yes.
Okay. So I would need to do some tests,
Okay,
include
doctor,
blood.
time. Okay, time finished, doctor.
Okay.
Time finished. It is the discussion time, but as usual, doctors, you will now write as we used in the course. also write in the chat box your score for Dr. Shamla. Then what do you expect the score will be out of 20 for the performance of Dr. Shamla? Then we will go back to the examiner discussion with Dr. Shamla. So please write in the chat box. I will be the only one who see the chat box. So okay. So Dr. Shamla, they are giving you a score between someone give you 23. So someone give you 3 marks over the full mark. Generally, you have they give you between 12 and 18. Wow.
Okay.
Thanks God you are not examiners or very tough guys.
Well, I think I would give me less than 10.
So, okay, and now it's another part that you need to share with doctors. Just write for me what's your, not the differential diagnosis, just give me what's the main diagnosis that you think in this case. So one doctor give me a correct diagnosis, the other correct diagnosis. Nice, good, good. Okay, I got a lot of correct answers. Perfect. Yeah, most of you gave the correct answer. Very proud of you, though. Okay. Okay, Dr. Walid, no. Dr. Latif, correct. Dr. Zahra, no. Dr. Muhammad, yes. Okay, okay. That's enough. Okay, so now it's the examiner time. So I want also to adjust the time. So I want to give you the correct feeling of the test. Okay, so now Dr. Shamla, we will start questioning. What is your differential diagnosis for this patient?
So I thought of duodenal ulcer.
Okay.
Next one I
Duodenal ulcer
considered
is duodenal ulcer is in the top of your if you're diagnosed. Duodenal ulcer improve or getting worse with eating?
I'm a little confused with gastric ulcer and duodenal ulcer relation to the food.
Yeah, how do you explain that the pain improve after 2 hours?
I don't know, doctor.
Okay, what are the chronic abdominal pain that aggravated by food, you know?
Mesenteric ischemia, but
Mesenteric ischemia, good. So do you think this patient has
yes,
the risk factors for mesenteric ischemia?
yes, of course he has.
Did you mention anything for this patient about this diagnosis?
No.
What are the risk factors in this patient that make the chronic mesenteric ischemia on the top of your list?
He has coronary artery disease. He has hyperlipidemia. He has hypertension. He has diabetes mellitus. He has even peripheral vascular disease. So I think that is the diagnosis.
And he's a current smoker, correct?
Yes, yeah.
And long history of smoking, correct?
Yes, sir.
Okay, what about cancer? Do you think is there a possibility of cancer in this patient?
Yes, sir. I even thought of gastrinoma. But then he doesn't have any other symptoms like any diarrhea or any.
Did you ask anything about anemia?
No.
So did you ask about the fatigue and you asked about the feeling of heart racing, but
Yeah.
being pale and weak and fatigue and all this stuff. Don't you think these are important questions to ask in this case?
Yes.
Especially with
I
this weight loss?
totally missed that. Yes, sir.
Correct. Okay. How to explain your diagnosis to this patient?
I think your condition is because of reduced blood supply to your tummy, especially after eating, which is causing the pain.
Okay. Is there a possibility of another differential diagnosis other
Other
than
than
you said peptic ulcer disease and you said chronic mesenteric ischemia? Anything else with this history can give this type of pain?
I'm not able to think of
Could
any,
we
sir.
consider pancreatitis?
Yes, chronic pancreatitis because of his alcohol history, hyperlipidemic history is
Yes.
possible.
How would you proceed with this patient, doctor?
I would request the current HbA1c level, lipid level. I would run one MRA, MR
Okay.
angiography,
Okay.
ultrasound abdomen.
Okay.
CT, I don't know because of his kidney function, if I can run a CT abdomen with contrast.
Okay. So you said MRA,
Yes.
or even can we do
Oh,
catheter
gadolinium.
angiography
Yes.
as well?
I'm not sure, sir. I have to check the kidney function, then I have to decide about if I can give that to
Do you have
gadolinium or
any
not.
idea about how to treat the mesenteric ischemia?
Same like coronary artery disease?
Yeah, but in general, do you know something what's usually done in that? Did you hear
uh,
about surgical revascularization or endovascular revascularization?
the nerve resection? No, no. I'm not
Okay,
sure,
doctor.
doctor. I'm
Time,
sorry.
time, finished. Okay, Dr. Shamla. Okay. Did you feel stressed?
I didn't feel stressed, sir, but I know I messed it up very badly.
No, you didn't. So the good thing that you did today, this is for everyone, for all of you doctors. The best way that Dr. Shamla did today, she was very confident. She went in the very nice order and the analysis of the diagnosis. And the great thing that she did, and this is why I'm telling you, she will get a good mark, better than what you gave here. Here is asking in details about the diabetes. And this is something that I want you to take home from our lecture today. And I will show you a slide for that. With every diabetic patient, you need to ask this question. And you did a great job in that, Dr. Shamla, when you went through the questions about the eye, the kidney, the food care, the hypoglycemias, and the diabetes control. Because many candidates, they just pass through the diabetes without asking this question. And believe or not, you might lose a lot of marks for doing that. So please be very careful when you analyze a patient with diabetes. You need to ask this question, and I will show you a specific slide for this one that you can follow and remind yourself whenever you have diabetes. I'm sure that the candidate in the course, you know the slides of diabetes, BNH. Okay, so this will be very important to remember. And if you are not with us in the course, just capture the screen and keep it on your phone. You need to follow with every diabetic patient. The other thing I like, Dr. Shamla, you asked it in a good order, just some few questions you missed. You didn't ask about the severity of the pain itself and the anemia. And the differential diagnosis, although you didn't give the patient the mesenteric ischemia as the cause of the pain, but you got that in the discussion. So you won't lose a lot of marks for that. Okay, and you answered the concern and was not bad about the possibility of cancer. Yes, it's still possible, but not on the top of the list in this patient, but you will still consider, and you need to go through all the investigations and the lab works and everything. One thing you missed also, the referrals. You need to mention to the patient that you are going to refer him. You are not going to treat such complicated case yourself in UK or anywhere. So you need to mention that there will be a team taking care of the patient, including a surgeon, including a heart doctor, including the gut doctor, all this stuff. So always try to write outside your possible differential diagnosis. And if you remember our slide of the abdominal pain, there is mesenteric vascular occlusion in the acute pain. And I already added that to the chronic pain in the updated slide. You will see it now. So I want you to see. So Dr. Shamla, you did great. I mean, don't worry about your performance. You went through most of the things. Your social history was nice. I like that you didn't waste a lot of time on the system review. You asked a very related question or relevant questions. So this is also a mistake that some of you, when you reach a diagnosis or you have a good differential diagnosis, please don't go and waste the time to ask all the system review. And one thing you missed, and if you remember in the course, I said many times, please be careful to ask this question, the impact on the life. Okay, the impact on the life. This patient with abdominal pain, he told you that there is an issue in his work. So please ask him this question clearly, because as I showed you in the first day of the course, I showed you the mark sheet. And one of the things that the examiner will see is the impact of the symptoms in patient life. This is in station 5 and in the history and in the communication. So if you didn't ask this question clearly, you won't get satisfactory for this part. So please remember to ask this question very clearly. Because he might tell you, I stopped eating. Yes, he did. I stopped going outside. I quit my work. Okay, so whatever. Ask this question very clearly when you are practicing in case of station 5 or history. Please write it outside, even not to, in order not to forget to ask the question. Okay. So now let's go. And so thank you very much, Dr. Shamla. In this case, I will give you at least 16 to 17. Okay, just for these few things. And if you have a nice examiner, you might reach 18 or 19. Believe me, this is an accurate evaluation, although you didn't reach the correct diagnosis with the patient, but you went through a very good questions and analysis, and you got the answer during the discussion. So thank you.
Thank you so much.
Now, thank you, Dr. Shamla. Thank you. Great. Keep going. When will be your exam?
So this November 8th.
Great. Great. You are almost ready. So very proud of you. Good luck.
So can I ask just one small question?
Yes.
So if in like my case, as I couldn't get the diagnosis with the patient, and if I'm telling in the discussion, will that be considered? If the examiners may
Yeah,
some
absolutely. The good thing is the question of the patient, the concern was not about the diagnosis directly, it was more about the cancer, and you answered a good question. Okay, you won't get a full mark without that, but it's way better when you get the diagnosis during the discussion other than you didn't even mention it. Okay, so you mention it and it is okay, but always remember to put a differential diagnosis. You remember we have a page for abdominal pain. We have a page for every diagnosis. So just write outside when you are in your paper, just write all the possible differential diagnosis. And now you won't forget that with this character of the pain or recurrent abdominal pain, just write everything and start to exclude the differentials. So don't worry if you catch that in the discussion, but please, some of you start pushing against what the examiner asking. The examiner might be pushing you toward the correct diagnosis, and some of you start to say, no, but it can't be this or that. So please, when you feel that the examiner trying to help you, and this is happening, very common to happen, please don't be very resistant, okay? Just say, yes, this is correct. Yes, I missed that. It wasn't my differential diagnosis. So just show him it's in your mind, okay?
Okay, so thank you so much.
Okay, don't worry. Okay, so now this slide is very important, doctor. I want you all to capture the screen for the diabetic question with any diabetic patient. Please remember this mnemonic, which is diabetic NPH. Okay, the diabetic NPH, the D for duration of the diabetes, since how this question didn't ask Dr. Shamla. So the patient with diabetes since 1 year is different than patient with diabetes since 20 or 30 years. Doctor, can you please close your mic? Let me see. I want to mute all. Let me see how. Just a second. Yes, I will mute all. Okay. Okay, so this is the first slide. I want you to capture the duration of the diabetes is very important, and the I for the insulin and other medications. So ask what's the medicine, and always consider the complication of the medication the patient used. Don't you think that some medications can cause chronic pancreatitis in this patient, doctor? Yes, it can, correct? It's one of the differential diagnoses in this patient. So you need to consider medications, okay, and detailed medication. Patient on aspirin, patient on sitagliptin. So aspirin and clopidogrel can cause peptic ulcer disease, and sitagliptin can also cause pancreatitis. Okay, so you need to consider, go in some details for the medications. Then the A for the A1C, you need to ask about the latest A1C as well. The B for blurring of vision and bloating. So you ask it. Usually I give the mnemonic just to remind you. But remember, when I say blurring of vision, I mean the eye effect of the diabetes. So you need to ask about the frequency of visiting the eye doctor and if there is any laser surgeries or something done for the eye, and you need to advise the patient to go there. Remember, you are treating the whole patient, not the whole condition, not only what the patient complained from today. So you need to advise, give a reasonable advice for a diabetic patient. So the eye exam yearly, they are linked together, the B and E. Okay, the T for traumatic and vascular foot ulcers and chalky joint and regular foot care. So you need to ask about the podiatry follow-up and the foot care. Then the I for infection, any recent infection. Okay, any increase in the blood, in the body temperature or any current infection. Then the C for cardiac risk factors. Remember to ask, even if not mentioned in the scenario, with any diabetic patient about the hypertension, the hyperlipidemia, and history of any strokes. The N for the nephropathy. So remember also to ask about the frothy urine, the color of the urine, and you did, doctor. Then the P for peripheral neuropathy, and you did also about pins and needles, and this is great, and neurology referral might be needed. Then the hypoglycemias, you can ask about the missed meals and the exercise, and you can mention the symptoms of the hypoglycemia because the patient might need adjustment of his medication or the exercising level or whatever, okay? So this slide is super important with any diabetic patient in station 5 or in the history. So in station 5, sometimes it's just simple case come with blurring of vision, and you need to examine the fundus, and all the marks won't be only on the diabetic eye changes, because some people ask why I get a bad mark in station 5, although I mentioned what I saw in the fundus examination, but you did a bad marks in that because you didn't ask these questions about the diabetes, because it's a diabetic case and they want to evaluate your ability as a general physician or family physician or the GB about the patient with diabetes. Okay, so this is very important to ask, doctor, please keep in your mind. The other slide that is important also, if you remember, this was in the first day of our course, is the slide that you will keep in mind. Just print all these slides and keep it in your wall or in your file, just to remind you when you have an abdominal pain case, you will remember this slide. Okay, so when we have abdominal pain, I want you to ask the Socrates, and I'm sure that all of you know what's the Socrates. So the S for the severity, and the last S for the site, and the O for the onset, the C for the course, the R for the radiation. You asked most of these questions except for the severity, Dr. Shamla. Then the A, what's increasing the pain, and the T for the timing of the pain. Okay, the A for the association, this is for the timing, and this is what exaggerating the pain or alleviate the pain. So remember to ask Socrates, it will give you a lot of answers. So timing is part of the Socrates. Relation to food and bowel motion, which is very important as well. Other person with same symptoms is important in the family, because sometimes it's just food poisoning or there is a family history. So asking this yellow question, as we used to see in all my slides and all my algorithm, okay, will be very helpful, because sometimes it gives you the answers very early. The other thing I want you to remember as well, and this will be very much appreciated and evaluated by the examiner when you ask early, is the alarm. Do you remember the alarm? Can you remember now? Write for me. Let me open your open the chat for everyone now, so you can write to, just a second. So you can write to everyone. Okay, now what you write will appear for everyone. So now you can write alarm. The A for what? What the A refer to? Okay, anorexia and anemia, I agree. What the L refer to? The L refers to what? L, loss of weight, perfect. The A for, the other A in alarm for anorexia, I agree. Then the R refer to what? The R, perfect. Recent progressive symptoms. Yeah, it seems like you watched the lectures. Give me a second. Who's writing on the wall? Please don't write on the wall. Clear all drawing. Okay, then the M referred to what? Melena, melena and hematemesis. Just remember, melena, vomiting out of blood or seeing in blood or black stool. Then the S refer to the S, swallowing difficulty. Perfect. So when you remember the alarm, okay, alarms, this will help you very much to ask the questions of the alarming symptoms in your exam. Okay, very important. Okay, the other thing is I want you to remember that if you have this page, it was in the notes of the day 1 in the course, day 1 or day 2. You can remind me, doctors. So this is for the acute and the recurrent chronic pain. Day 1. Yes, thank you, Dr. Iman. Yes. So in the acute abdominal pain, you need to remember pancreatitis and the risk factors, what can cause pancreatitis, and remember the character of pain of the pancreatitis, and we will go to that in the next slide. Then the mesenteric vascular occlusion, the acute one, and the Budd-Chiari syndrome. I will also give you some hints about that in the next slide. Then the abdominal aortic aneurysm, okay, and the risk factors for that. The peptic ulcer disease and the cardiac causes of acute abdominal pain and the food poisoning. And we will discuss exactly how to ask and what to try to see with the acute abdominal pain, but I want you to write that outside. If you are not with us in the course, doctor, please capture the screen. Okay. Then with recurrent abdominal pain, remember the word acid pH, Okay, because also without asking this question, without memorizing this differential, you might be, especially in station 5, you might be under the stress of time and you might lose the hidden diagnosis. So for the A, and here it's yellow because it's very common in the exam. Addison disease as abdominal pain, and please can you tell me in the chat box what is other than abdominal pain you will see in Addison disease? Just give me the screening questions. Then acute porphyria and angioedema. And the problem with acute porphyria and angioedema, it is something that you can really easily miss. Okay, so please be careful not to miss these cases. I will go also through the discussion. That's why I'm telling you today is very important, even for the doctor not in our course. You might easily miss the case of angioedema, which is very common in the exam. It's very common to get the patient with abdominal pain and the diagnosis is angioedema. And the acute porphyria, and the problem with acute porphyria, if you don't know the acute porphyria, you won't be able to answer any question about it, especially with the patient. So please be careful to learn some stuff about the acute porphyria, and I will discuss now. So yes, the answer is great about the postural hypotension, tan skin, dizziness, weight loss, hypotension, exactly. These are the Addison screening question. And if you catch it's Addison, remember our discussion of Addison in the cases of the dizziness and the syncope in day 4 in the course. So once you catch Addison, you need to go and search for the cause of the Addison and search for the hypoglycemia of the Addison. So don't stop at the point of Addison, you need to find the cause, correct? As we discussed in day 4, you should know it's not enough to say it's Addison, okay? Then the acute porphyria and angioedema, and I will go in details for that. Then they see here for chronic mesenteric ischemia and for colics, whether it's renal colic or biliary colic. So remember also, so here we add this part, doctors, because we used to ask about mesenteric vascular occlusion in the acute, but you need to ask about them in the chronic. Don't you think, doctors, we need to ask the 7 questions of clotting in any case of ischemia? Don't you think it's important questions? Yes, you need to ask the questions for the risk factors, and this would be great also if you ask Dr. Shamla in this case. You need to go through the 7 questions of blood clot. Can you please write them on the chat box, doctor, if you remember? Just write 1. Remember, we need to exclude a personal history of blood clot. Remember that we need to exclude family history of blood clot. Remember that we need to know about smoking and heart problem. You asked all these questions, Dr. Shamla, already. But remember that we need to exclude basic disease by asking about genital sores and mouth sores and joints problem. Remember that we need to exclude nocturnal hemoglobinuria, and you asked about the dark urine color, especially in the morning. And remember, you need to ask also about the antiphospholipid syndrome with recurrent abortion if the patient's female with the skin rash and photosensitivity and association with SLE. Okay, so these are the 7 questions of clot that we keep repeating in the course every time when we are talking about any blood clotting problem, okay? Then the I refer to inflammatory bowel disease and irritable bowel syndrome. Inflammatory bowel disease is also very common to see in the exam, Crohn's and ulcerative colitis, and you exclude that by having previous surgeries for the Crohn's disease and weight loss. So weight loss in the patient with severe abdominal pain, you should consider inflammatory bowel disease. And if there is also a mucus or white mucus with the stool, and if there is a blood with the stool, so you need to consider inflammatory bowel and irritable bowel syndrome. And we discussed that, and I will discuss it in the next slide as well. The D for DKA, insulin-dependent diabetes. If the patient is diabetic with type 1 and coming with recurrent abdominal pain with very uncontrolled blood pressure and all blood sugar and all these DKA, it didn't came before as the case because usually it is ICU case, but just to keep it in your differential. Okay, the P for polyarteritis nodosa. It's also not common in the exam. It's a rare condition, but I will give you a hint about it. So in case you face this, I don't want you to miss the case. Then the F, which is common in the exam for the FMF, the familial Mediterranean fever. So remember, this circle is important with Addison, acute porphyria, and angioedema. Mesenteric ischemia is important, and FMF is very important as well. Okay, so please capture this page and tell me if you found it helpful. Okay, so now let me go to the next slide. I will just show you here this slide for the acute abdominal pain, and I think you all guys in the course, you received that before. For the pancreatitis, the pain will be epigastric, radiates to the back, increased by eating, decreased by leaning forward, maybe with diabetes mellitus, may cause diabetes mellitus if it's chronic. And you remember this, it's not mine, this is the mnemonic for get smashed for the causes of the pancreatitis, which include gallstone, ethanol drinking, trauma, steroid, mumps, autoimmune, scorpion sting, MRCP, drugs. Okay, so I want you to ask this question if the case of acute pain, acute pancreatitis. So acute mesenteric ischemia, you will ask the 7 clotting question, and you will ask about the Budd-Chiari syndrome. Just for Budd-Chiari syndrome, because this was not in your slide, I added that for you. Just remember the risk factors for the Budd-Chiari, which is 4 Ps. Okay, for the Budd-Chiari syndrome, please remember to ask about pregnancy, to ask about oral contraceptive pills, to ask about thrombophilias, and to ask about the PNH, the paroxysmal nocturnal hemoglobinuria. Okay, so these are, and ask about liver cirrhosis and chronic liver disease, and ask about cancers, ovarian cancer or any cancer can block the portal vein. And the symptoms of Budd-Chiari is abdominal pain, ascites, hepatomegaly, okay, jaundice, lower lymphedema, and deteriorated liver function test results. Okay, so please, because Budd-Chiari appeared in the exam last year. Okay, so it's something that you need to ask about the causes and the signs and symptoms. Then for the cardiac pain, it will be exertional. So it's important to ask if this pain relieved with exertion, increased with exertion, epigastric, might radiate to the jaw and the arm, associated with dyspnea and chest pain. So remember, in such case, let me again close the mics. Okay, just a second. Let me mute all. Okay. Okay, and for the peptic ulcer disease, the pain will be epigastric, burning, radiate to the back, related to food or fasting. So I know that you all know that, but I want you to have that in slides, and I want you to remember how to practice that exactly without forgetting anything. Okay, so don't forget the Budd-Chiari syndrome, please. And now I will just give you a brief discussion about the acute porphyria. So please, if this is the first time you review a case of acute porphyria, please try to remember what is in this slide. I won't go in that in details. I know, guys, I discussed that in the course, so you will know about it. But just to give you a hint, for acute porphyria, there will be abdominal pain, maybe constipation, nausea, and vomiting, CNS symptoms, depression, insomnia, schizophrenia. So remember that CNS symptoms might include seizures, and patient might have depression. And there will be pins and needles in the hand. If you remember the case in the course, it was patient with abdominal pain and tingling of the hand. There is also a port wine colored urine, and they won't give you this answer if you didn't ask, because if they put it in the stem of the question, it will be very easy case. Then the most important part is the exacerbation. What exacerbates the acute porphyria? Okay, so remember that steroid and oral contraceptive pills and anesthesia, including barbiturate, alcohol, and the patient might be on diet. So patient on low carb and low calories diet, okay, or dehydration, this might severely exacerbate acute porphyria. Acute porphyria and mesenteric vascular occlusion is very common that they will be missed in the exam and in real life. So it's clearly mentioned that it's common to be missed. The patient might need to go to many doctors until they get the diagnosis, even the angioedema as well. Of course, so remember the exacerbation, then the age usually between 18 to 40. Okay, and it happened due to the deficiency of profibrinogen, deaminase. So we will expect urinary and serum profibrinogen to be high and genetic testing. And usually the treatment is avoid the precipitating factor, high carb diet. Sometimes we admit the patient to give him glucose and hematine and painkillers. Okay, so please be careful with this case. It might come in the exam, it came before, and I don't want you to go to the exam with something you know nothing about. Okay. The other thing about, so I'm a little bit fast because I know that most of you is with me in the course or attend the course with me before, so we went through these cases. If not, just capture the screen and read that. And these are the bundles, and I won't go through them, but you know we have two approaches for the history cases. The first is the bundles, and the second is the regular history approach. So please also keep these pages so you can follow in your history cases. Okay. And remember here, the impact on life. I highlighted the impact on life because it's really important and it's frequently missed by the candidate. Never forget to ask about the impact of life. So how identify, how and why. I receive a letter from your GB for then Socrates, then impact on the life, then discuss the differential, then quick relevant systemic review. And I told you how to reach the relevant systemic review, not for everything. Then ask all this structure, then the concern, then the plan of management. So usually if you follow this page, you won't miss anything. And this is the page of the system review. So please capture that if you don't have it, okay? So in this page, I'm showing you the chronic causes of abdominal pain. So Addison disease, and as you said, guys, in the answers, postural hypotension, pigmentation, hypoglycemia, acute porphyria, and we just discussed angioedema, and we will go to the angioedema in the next slide. Then the polyarteritis nodosa. I don't want you to know much details, but just having joint pain, rash, testicular pain, abdominal pain, and history of hepatitis B virus. Any of these might take you, dark urine as well. So any of these might take you to the polyarteritis nodosa. And there is a slide that also you can print in case you want to read it. Not very common, but you need to see it, okay? Then the FMF, which is very important, okay? The origin of the patient, the family history, the sinusitis, okay? Synovitis, peritonitis, and pericarditis, and chronic recurrent, okay? And also you have the inflammatory bowel disease, you have the irritable bowel syndrome. Remember with the irritable bowel syndrome, please write in the chat box, what will you ask in the irritable bowel syndrome? And I want to hear something. For irritable bowel syndrome, it is a diagnosis by exclusion. So please don't assume the case is irritable bowel syndrome before excluding every serious other symptoms, please. Yes, correct. If it wakes, does it wake you up at night? Does it relieve with the, after the bowel motion? If there is any alternation between diabetes, between diarrhea and constipation, okay. And usually there might be a family history of that as well. Presence of mucus with stool, great. Yes, these are the questions that the examiner will understand that you're asking about irritable bowel syndrome. And for the inflammatory bowel disease, remember the extra intestinal manifestation as well. For the API sac, which is aphthous ulcer, bioderma gangrenosum, iritis, and erythema nodosum, sclerism cholangitis, and arthritis, and claving of fingertips. So just to remember, again, you can capture this page. There is nothing tricky. I will waste the time on because we can go and discuss more important topic. Then angioedema. For angioedema, and I think if any of you attend the test before, 2 years ago, they brought it in most of the centers and many doctors lost this patient. So please be careful. Angioedema, sign and symptoms will be face swelling, frequent attack of face swelling. It shouldn't be present at the moment, but there will be a history of face swelling, sometimes difficulty of swallowing, abdominal pain due to intestinal swelling in the stomach and bladder problem. And usually it can give a picture of surgical abdomen. And in the history, they might give you the patient removed his gallbladder, have appendectomy done, and still have the same pain. Shortness of breath due to bronchospasm with the angioedema itself. So usually you might see a long history, okay, a long history of attacks of angioedema and allergy. But remember, with angioedema, you won't see rash. It's not something that will come with rash, okay? Then the family history, it's autosomal dominance, so it won't skip generations. But remember, the history might be a little bit confusing because they might say I'm adopted, and there is also some condition with incomplete penetration. So there might be, although it is autosomal dominant, there might be skipped generation. So don't depend on the family history only in angioedema, just depend on the past history. Okay, then the face, swelling, throat, skin, and abdomen, you need to examine in station 5. And these are the investigation you will do: the low C1 esterase inhibitor, low C4, the imaging, you will need ultrasound and CT. Okay, and you will see thickening of the walls. And the treatment is usually C1 INH concentrate, adrenaline, and there is what's called plasma kallikrein inhibitor. You don't need to know all these details, but if you got the diagnosis of angioedema in your case or ask about it, the examiner will be very impressed. And if it is angioedema, believe me, if you reach the angioedema diagnosis, you will get a full mark. And this is a picture of one patient with this angioedema, and shouldn't be there all the time, okay? Okay, doctors who are asking me for going back to the pages, by the end of the lecture, I will go back to this slide, what slide you want, just to capture. So don't worry about that. Just focus on what we are discussing now. Then I will go back to the slides you want to capture. Don't worry, okay? For the FMF, please remember, there will be a fever, abdominal pain. It's something that frequently missed as well. The patient will come to you many, many times with abdominal pain and will be misdiagnosed with Crohn's disease, with appendicitis, with cholecystitis, the same as angioedema. Okay, and sometimes constipation during the attack, then they got diarrhea after that. Then sometimes chest pain because it causes also sinusitis with pleural and pericarditis pain. Then joints pain because there will be synovial symptoms. I'm sorry for being very fast, but because we want to go through all of these. And remember that you will, in our course, we went through this, so this is not new for you, okay? Then for the rash, mainly in the lower limb, then amyloidosis. And remember that proteinuria and amyloidosis and renal failure is the main cause of death for this patient with FMF. Just clinically, you might, a diagnosis is clinical and genetic testing for MEFV mutation. Remember what you can, and then the labs, you will ask for routine labs. You will ask for ESR and CRB and amyloid. Okay, you will ask about amyloid A protein and white blood cells, urine analysis for proteinuria, and synovial fluid analysis, then imaging according to the complaint. You also can capture that if you want. Biopsy may be needed for amyloidosis, and the treatment is usually colchicine and biologics. Again, for the polyarteritis nodosa, there is constitutional symptoms like fever, malaise, anorexia, weight loss, arthralgia. So the patient will have abdominal pain and he will look weak and tired like the cancer patient. There might be CNS symptoms, including seizures and mononuclear blindness. A peripheral neuropathy in the skin, there might be rash, purpura, okay, digital ischemia and ulcer. Genitals, there might be, in the genitalia, there might be testicular pain. It's common to have a testicular pain in the pan. Abdominal pain, nausea and vomiting, and melena, and hypertension and renal failure. And remember, with the history, also that you might find hepatitis B. And it's usual to put a hepatitis B for that to guide you toward the case, but put it in your differential diagnosis, please. So these were the fast and brief revision of the abdominal pain that we went through. So please remember the first page and remember the approaches. So for the doctors asking me for the approach, this is the one. This is the one for the bundles. And this is the one for the regular history approach. And this is the one for the system review. If you want to capture. And please remember us in your prayer. Okay, doctors. Now I have questions for you. do you want to proceed for the next case, or it's enough for you and you want it to be next week? Give me the answer on the chat box. You want the next case? So most of you said, oh, next week, please, next week, please. Okay, next week. Oh, next case. Okay, so let's proceed. Let's proceed with the next case very fast. And I promise you, in the next week, I will give you a great approaches for in communication. We will discuss interesting cases in communications. But let's take another case, another history case, very fast. I won't go in a lot of details in that, because I will point to a lecture that you can watch in my YouTube channel. It will explain exactly how to approach these cases, but at least we will practice this case and you will learn something from